Hello everyone, welcome to Miss Doc T. This is Dr. Farheen, General Medicine resident, and today let's discuss narrow complex tachycardias. In this video, you will learn the ECG interpretation of sinus tachycardia, multifocal atrial tachycardia, atrial flutter, atrial fibrillation, and paroxysmal supraventricular tachycardia. So let's get started. First, we'll look at some questions. Identify the ECG given below. A 35-year lady was diagnosed with anxiety and neurosis. She had palpitations. Comment on the diagnosis based on the ECG. A 52-year male, known case of COPD, showed the following ECG. What is the diagnosis? A 45-year male came to the emergency department with recurrent palpitations. ECG was performed. What is the immediate next step of management? I know it's very confusing if you are a beginner, but by the end of this video, you'll not only be able to answer these, but will also understand why the other options are incorrect. So without any further delay, let's get into the topic. Now let's suppose this is a heart, this is the SA node and this is the AV node. Normally, the impulse starts from the SA node, contracting the atria, then it passes to the AV node, then through the bundle of His and Purkinje fibers, it causes ventricular contraction. So depolarization of atria causes the P wave, and then depolarization of ventricles causes the QRS complex, and repolarization causes the T wave. Now tachycardias means the heart rate should be more than 100 beats per minute. So how to see rate in an ECG strip? So let's look at the strip. So first mark the two QRS complexes and then count the number of large boxes present between the two QRS complexes. So in this picture there are 4 large boxes between the two QRS complexes. The rate is calculated by 300 divided by the number of large boxes between the two QRS complexes. So that gives 300 by 4, a rate of 75 beats per minute. Now we'll look at another ECG where between the two QRS complexes there are only 2 large boxes. So the rate is 300 divided by 2, which is 150 beats per minute. So a rate more than 100 beats per minute indicates there is tachycardia. So in an ECG strip, first see if there is tachycardia or not. The second step to see if there is tachycardia is to look at the QRS complexes. The morphology of QRS complexes may be of 2 types. So this is a strip. First see if there is tachycardia. Between the two QRS complexes there are 2 large boxes, so the rate is 150 beats per minute. That means there is tachycardia. Now look at the morphology of the QRS complexes which are narrow. So this indicates narrow complex tachycardia, and narrow complex tachycardia indicates origin of the impulses above the level of ventricles. This is important to remember. Now another ECG. First let's see the rate. Between the two QRS complexes there is only one large box, so the rate is 300 by 1, which is 300 beats per minute. So there is tachycardia. Now look at the morphology of the QRS complexes. They are wide. So this kind of tachycardia is known as wide complex tachycardia, and this indicates the origin of the impulse is at the level of ventricles. Now, narrow complex tachycardia indicates origin above the level of ventricles, so it could be from the SA node, from the atria, or from the AV node. So in this video, we'll look at narrow complex tachycardia. Now we'll look at the SA nodal cause of narrow complex tachycardia. So normally SA node is the pacemaker of heart, and this is how a normal rhythm looks like. And now compare it with the second picture. So in the first picture there is P, QRS and T, and all the complexes are normal in morphology and in a normal rhythm. In the second picture also the morphology of all the complexes is normal, but they are occurring in rapid succession. So normal complexes in rapid succession indicate sinus tachycardia. Now we'll look at an ECG strip. So first see if there is tachycardia or not. So between the two QRS complexes there are about 2.5 large boxes, so the rate comes to around 120 beats per minute. So there is tachycardia. And now look at the morphology. There is a normal P wave, a QRS complex and a T wave. But these complexes are occurring in rapid succession, so that indicates there is sinus tachycardia. So remember, in sinus tachycardia, the morphology of all the waves is normal and the complexes are normal, but they are occurring in rapid succession. Now the second cause of narrow complex tachycardia is atria. In the atria, we'll look at multifocal atrial tachycardia, atrial flutter and atrial fibrillation. Now we'll look at multifocal atrial tachycardia. So normally from the SA node, the impulse that is generated contracts the atria and then it passes to the AV node, then through the bundle of His and the Purkinje fibers, it causes contraction of ventricles. But here, as the name indicates, there are multiple foci in the atria which will cause impulse generation. So instead of the normal SA node, impulse is generated from ectopic foci from the atria. Now what happens is, now let's suppose the picture shown on the right is a normal conduction system of heart. So this ectopic impulse causes an abnormal conduction of atria, and then when it reaches the AV node, it passes through the normal conducting system causing contraction of ventricles. So here only the contraction of atria is through an abnormal pathway, whereas the contraction of ventricles is through a normal pathway, and that is why the P wave morphology is abnormal whereas the QRS and T is normal. Similarly, another impulse is generated from another ectopic foci which will cause an abnormal contraction of atria, and then when this impulse reaches the AV node, it passes through the normal conducting system to cause contraction of ventricles. So again the morphology of P wave is abnormal whereas the QRS and T have normal morphology. Similarly, another focus will cause abnormal contraction of atria, and when it reaches to the AV node, it passes through the normal conducting pathway into the ventricles, and so the morphology of P wave is abnormal whereas the QRS and T is normal. So here there are abnormal morphological patterns of P wave. More than 3 morphological patterns of P waves in an ECG indicates multifocal atrial tachycardia, and this is most commonly associated with pulmonary diseases like COPD. This is very important to remember because this could be a hint given in the question. So remember, there are more than 3 morphologies of P waves, and the QRS complexes will have normal morphology, that is narrow complexed, but the rhythm will be irregular because this is produced from some ectopic foci generating in the atria. So it causes an irregular rhythm. Now let's look at an ECG. So in this ECG, first thing is to see that there is tachycardia. Between two QRS complexes, there are 2.5 large boxes, so the rate is 120 beats per minute. There is tachycardia. And now look at the morphology of P waves. So in some it is tall, tented, in some it is inverted. So more than 3 morphologies of P waves indicates multifocal atrial tachycardia. So in this ECG strip, there are more than 3 morphological patterns of P waves, and also the QRS should be narrow complex with an irregular rhythm. Now, treatment of multifocal atrial tachycardia is first to treat the underlying cause, and the second is to control the rate by using beta blockers or non-dihydropyridine group of calcium channel blockers. Now we'll look at the second atrial cause of narrow complex tachycardia, that is atrial flutter. So let's suppose this is the tricuspid valve, this is the superior vena cava, and this is the inferior vena cava opening into the interior of the right atrium. And in some people there is a fibrous band between the inferior vena caval opening and the tricuspid valve, which is known as the cavo-tricuspid isthmus. So this fibrous band causes re-entry of an impulse again and again back into the atria. So it acts as a re-entrant circuit. That means the impulse that reaches this fibrous band will be circulated within the atria itself, causing atrial contractions again and again. And finally, sometime it reaches down to the ventricles, causing a ventricular contraction. So depending upon how many times the atria is getting contracted, the P waves are produced. Suppose the atria is contracting 2 times, 2 P waves followed by a QRS occurs. And suppose the reentrant phenomenon is causing the atria to contract for 3 times, then 3 P waves followed by a QRS complex occurs. The morphology of this P wave is known as a saw-toothed P wave, also known as Flutter Waves, and these are because of the reentrant phenomenon. So on an ECG, see that the P waves are saw-toothed in morphology and the QRS complexes are usually regular. And the P wave is to QRS complexes can be in the ratio of 2:1, 3:1 or 4:1 depending upon how many times the impulse is causing atrial contraction. Now we'll look at an ECG. So here very clearly you can see the flutter waves. So there are 3 P waves and then there is a QRS complex. So this is a 3:1 type of flutter. Now we'll look at the third atrial cause of narrow complex tachycardia, that is atrial fibrillation. In atrial fibrillation, many weak impulses are produced from many different foci of the atria, and these are not strong enough to produce an atrial contraction. So there is no P wave. And randomly, some impulse reaches the ventricles leading to ventricular contraction. So there is just a ragged baseline because of the weak atrial contraction, and whenever an impulse causes ventricular contraction, there is a QRS complex. So there is a ragged baseline and then a QRS complex whenever the impulse reaches the ventricles. So this is how the ECG looks in an atrial fibrillation. So the impulses in the atria are so weak that there is no proper atrial contraction, and so the P wave is absent and the QRS complexes occur irregular. And these waves are known as the fibrillary waves. In long-standing atrial fibrillation, even these fibrillary waves are absent, and the ECG may look something like this, just with irregular QRS complexes. Now we'll look at an ECG. So here, very clearly the QRS complexes are occurring irregular, and there are fibrillary waves. Also, there is no P wave here before the QRS complexes. So this indicates atrial fibrillation. Now coming to the treatment of atrial fibrillation, if the patient is unstable, then cardioversion is done, and if the patient is stable, the first line is to do a rate control by giving beta blockers or calcium channel blockers. This is followed by rhythm control by giving antiarrhythmics or electric cardioversion, and then the third step is to prevent thromboembolic complications by giving anticoagulants. So atrial fibrillation has a high risk of thromboembolic phenomenon, so anticoagulants should be given. So remember, the first thing is rate control, then rhythm control, and then prevention of thrombotic complications. Now in narrow complex tachycardias, we have discussed the SA nodal cause, that is sinus tachycardia, the atrial causes, namely multifocal atrial tachycardia, atrial flutter, and atrial fibrillation, and now we'll look at the AV nodal cause. The most common is the AV nodal reentrant tachycardia, and it is synonymously used with paroxysmal supraventricular tachycardia. So here what happens is that the AV node generates an impulse that simultaneously contracts both atria as well as the ventricles. And because the atrial contraction is weak, the P wave will be hidden inside the QRS complexes. So here only you can see the ventricular contraction part. So there is QRS and T waves, but the P wave is hidden inside. Sometimes it can be seen like a notch. So a P wave is hidden in the QRS complexes, and also the QRS complexes are very narrow and they occur regularly. So look at this ECG. Here there are QRS complexes which are narrow and there are T waves in between, but there are no P waves. And these complexes occur very regularly. And the treatment part of paroxysmal supraventricular tachycardia is really important for PG entrance exam, and the first line is carotid massage or IV adenosine. So this is what we have discussed, and now we'll get back to the questions. Identify the ECG given below. Now in sinus tachycardia, the complexes morphology should be normal. Only thing is that they will occur in rapid succession. In paroxysmal supraventricular tachycardia, the P wave is hidden and also the rate is very high, more than 250 beats per minute. In atrial fibrillation, there are fibrillary waves and irregularly occurring QRS complexes. And in atrial flutter, there should be sawtoothed P waves. Now in the ECG, very clearly the QRS complexes are irregularly occurring and also there are fibrillary waves and the P wave is absent. So this ECG shows atrial fibrillation. Next, a 35-year lady was diagnosed with anxiety neurosis. She had palpitations. Comment on the diagnosis based on the ECG. Now again in atrial fibrillation, there should be fibrillary waves and irregularly occurring QRS complexes. In sinus tachycardia, normal morphology of complexes occurring in rapid succession. Now we'll look at the ECG. So there is P wave, there is QRS and there is T wave. So again P, QRS and T. And the complexes are normal in morphology, just they are occurring in rapid succession. So this ECG shows sinus tachycardia. Now why is it not an atrial flutter? Because in the ECG, the sawtoothed pattern of P waves is not seen. And why is it not a paroxysmal supraventricular tachycardia? Because the rate should be very high. more than 250 beats per minute, and also the P wave should be hidden inside the QRS complexes. So only the QRS and the T waves are usually seen and the P wave is hidden. Now the next question. A 52-year male, known case of COPD. So COPD is the hint that is given in the question. Showed the following ECG. What is the diagnosis? Again, in atrial fibrillation, there should be fibrillary waves with irregularly occurring QRS complexes. But here in the ECG, very clearly P waves are present before the QRS complexes. So it is not AF. In paroxysmal supraventricular tachycardia, the P waves should be hidden inside the QRS complexes, and also the rate should be very high, to about 250 beats per minute or even more. And in multifocal atrial tachycardia, there should be different morphologies of P waves. At least more than 3 different morphology of P wave should be present. So here, if we can see the morphology of P wave, in each complex it is different. In some it is inverted, in some it is upright, in some it is tented, and in some it is short. So this ECG shows multifocal atrial tachycardia. Also, remember that this multifocal atrial tachycardia is commonly associated with COPD. So COPD is a hint to diagnose multifocal atrial tachycardia. Now why is it not sinus tachycardia? Because the morphology of the complexes should be normal in sinus tachycardia. Here the morphology of P wave is abnormal, so it is not sinus tachycardia. Next, a 45-year male comes to the emergency department with recurrent palpitations. ECG was performed. What is the immediate next step of management? So in the ECG, the QRS complexes are very narrow and the rate also is very high. Here, between the two QRS complexes, the T waves are seen. So this is paroxysmal supraventricular tachycardia, in which the first line of management is either carotid massage or IV adenosine. So among the options here, adenosine is the answer. Electrical cardioversion is done if the patient is unstable. Okay, so this was a quick look ECG session of narrow complex tachycardias. I just wanted to make the interpretation of ECG more simple, and I hope it was really useful to all of you. And that's all for today. Thanks for watching. Hope you liked it. Let's meet again with another video on quick look ECGs. Till then, just take care, be happy and stay safe.